Today, we are starting a new series, a series with experts, meeting with experts. About 2 years ago, in March 2021, we had our first English meeting with Dr. Sartorius, and there we called him as the master of transgenerational periods. He is indeed so. And today we will be having an hour session where students, early career psychiatrists will be able to ask him questions about mental health and also relations of public health with psychiatry. We are planning to have the moderation together with Ramin, our young friend from Malaysia. Ramin, would you like to ask the first question to Dr. Sartorius?
Sure. I could do that. Yeah, first of all, good day, Professor Sartorius. It's always nice to have you in our meetings. And yeah, good day to everyone else who is in this meeting with us and whoever might be watching on YouTube. Perhaps let's just go right into it in the interest of time. I'd like to ask a rather broad question first, if you don't mind, Professor Sartorius. I'm actually interested. What drives you to do what you do?
Well, it depends on the moment. It depends on the time when this question is asked. It depends also on the time of my age. When I was 20, I was driven by other maybe some different kinds of motivations. So I think that the question would have to be more specific. Would say, what drives you to do this or the other at a particular age, in a particular time? Because to give a general description would be, in fact, giving you my biography, which would take a great amount of time and would not tell you sufficiently to answer your question.
Okay, perhaps we could start with what drives you as a psychiatrist?
Yeah, well, I think that's, I didn't want to become a psychiatrist in time. Just 1 second. Veri se zatvori vrata. Originally, I didn't want to become a psychiatrist. My first choice was to be a pediatrician. But then, since my mother was a pediatrician of some reputation, I thought I would be forever known as the son of the great pediatrician. So I didn't want that. Then my second choice was ophthalmology, but that was not possible either because there was no room. And the only place where I could have at the time postgraduate education was in psychiatry. So I took psychiatry. As time went by, I discovered it's a wonderful discipline, and I'm very pleased that I took it. But in the very beginning, my primary motivation was not psychiatry. As I think about it now, probably it was because psychiatry was not, the instruction in psychiatry for medical students was not particularly neither interesting nor very good. And therefore, very few of them wanted to become psychiatrists. Later on, in my medical school where I grew up, they introduced a variety of things which changed the situation. They have, for example, done epidemiological studies, and all the field research was done by medical students who went and spoke with people and got familiar with the instruments and got familiar with the problems and were involved in the analysis of the results and the writing up, etc. And they became very interested in this. And they also met, at the time, psychiatrists and epidemiologists, both of whom were interested in them. And so they, later on, a large number of them became psychiatrists. because they understood what it was all about, and they liked what they understood. So that as many other medical students, it's very rare to know exactly where to go, and it's very often a matter of chance which discipline you will take. Very few people know from birth on that they will become surgeons or orthopedists, etc. There are so many influences to select one's specialization.
Yes, I think you brought up a very interesting point that psychiatry in our medical schools, I think it's all over the world. And even now, we are still trying to improve the exposure of psychiatry to medical students. I think it's something that we can still very much improve on, especially with regards to seeing patients, dealing with stigma, and all these issues that come associated with it as well. May I just ask, in relation to this question, once you got into your psychiatric training, you mentioned that you realized that psychiatry was beautiful and interesting to you. What got you hooked to it, and what kept you in psychiatry?
Well, it wasn't like that. When I first came, eventually I started volunteering as a postgraduate student. And what I saw at the time was not very encouraging. The psychiatry at the time was really using a variety of methods that were anything but attractive. The insulin comas and electroshock and the metrazole shock and a variety of other treatments of that type. The mental hospitals at the time were huge, and the life in these mental hospitals wasn't a very attractive proposition. And when I say huge, they really were huge. The mental hospital, for example, in Pilgrim State Hospital was having about 12,000 patients and about 7,000 staff. So I mean, it's a whole town that was a hospital. Even in Epsom in England, there was a similar number of patients who were there. And the treatment which psychiatry had at its disposal was not particularly attractive either. So that being in psychiatry, what really became a very important thing is how can one improve the quality of life and the behavior towards patients who are in there, and how can one think of ways in which one could maybe find solutions for people not to stay there for too long. But that was all. Then came the question of whether psychopharmacological treatments will in fact help that. And they did to an extent help, because they have helped us to reduce the excitement and the acute forms of disease. But even then, even with that, psychiatry is not a particularly cheerful discipline. There are still, if you want to do psychiatry and take everything into account, not just a mild depression, which can be treated by the general practitioner or by a doctor, but if you really want to look at the whole of psychiatry, it really is a discipline which in many fields lacks in effective treatment. And so we have to think about creating a life for people who are not completely well for a long time.
Yeah, these I think what you mentioned when you said that it's not a particularly cheerful profession. I think maybe that is the case for certain illnesses, probably, which we are seeing. I mean, I'm sure you know much better. What about patients whom you see more often, like, for example, in the clinic with depressive patients, patients with anxiety?
Yeah, well, it's a little different. First, the psychiatry contains a variety of techniques, of skills, which can be useful in medicine in general, not only in psychiatry, but also in medicine in general. Because there is no patient who has a physical illness who is not at the same time anxious and uncertain and needs some help and needs support, etc. And many of the skills of providing insurance and support and etc. depend on on one side of empathy, on the other side of techniques, which psychiatry has developed over time. It's good doctoring, I think, contains many of the things that are particularly developed in psychiatry. So that's one aspect of the story. The second one is, of course, that psychiatry has a variety of possibilities of prevention, of primary prevention of mental illness. And if psychiatrists establish a contact with the public health authorities and with other people in the medical field, they can do a great deal. Unfortunately, they don't do sufficiently to think about prevention, but could do a great deal to also prevent mental illness. A good example is it would be a wonderful development if psychiatrists were to they participate in perinatal care when a woman comes to be examined, not only to discover whether she has depressive symptoms or not, but also to add to reduce the anxiety which people have about children in general, how will this happen, etc. To think also of other ways in which one could help the mother, the child, and the father to grow better. And that's perinatal care. But there are many other disciplines in many other places where the skills of psychiatry could be extremely helpful and where they should be used at much larger degree. Of course, they should be used also for treatment of psychiatric disorders. And for many of them, we are now in a position that we can reduce both the duration and the severity of the condition. There are still some mental disorders where we cannot do this, but even there, if we provide them a life which is a decent survival life, like a person with dementia or others, we can do a great deal to make this life more tolerable. And we know a great deal about this, but it's not sufficiently applied.
Perhaps we can move to another question.
Before you move to another question, can I see the faces of people who are present?
Yeah, I also...
Yes, and Irem Kechachi and Zehra. Is it possible that we see them?
Yeah, please, Sena, Irem, Zehra, could you put on your videos?
Good morning, Zehra.
Good morning.
Yes, this is much better, yes.
Open it in a minute.
Yes, very good. And Irem, where is he or she?
I will just open my video in a minute. Excuse me.
Please do so.
All right.
And be ready to ask questions. Let Ramin be not the only one asking questions. Ferhat, Miraj.
I actually have a lot of questions. I don't know where to start.
We go to Miraj.
Perhaps, yeah, Miraj, you can take over from here. No problem.
I might start with the research-related questions. I know now psychiatry has, in psychiatric research, the neuroscientific research gained a lot of popularity where people investigated fMRIs, structural brain imaging, receptors, neuronal types, and their transmission through brain, how the etiologic mechanism, in the brain plays a role in psychiatric disease. And this has a lot of money spent on that kind of research, but we haven't received a great result that impacted the quality of life of psychiatric patients and so on. So now there is a criticism that emphasizes that we should more focus on the research that aims to increase the quality of life of the psychiatric patients. So I wonder if it's always like that. In the previous time, as someone you see many generations through psychiatric research and psychiatric literature. What would be your suggestions on the focus of this research? And was it always like that? Always the people spend more money on the basic scientific research, or should we more focus on more intervention-based research, like effect of psychotherapies, which sort of therapy or rehabilitation program is more effective? Well,
the money which is being spent to help people with mental illness, at present, you have the impression that there is a lot of money that comes from research. But in fact, the largest amount of funds or largest proportion of funds which are given for the treatment of mentally ill people are given by families. It's a huge influx of money that is being invisible. Nobody speaks about it, and we are talking about community care as if, when you have a community care principle, you have a patient and you put him into the community. Now, and then they say this is a very good measure. But in fact, what you have done is you have transferred the bill for the patient's health from the institution to the family. And the family now contributes massively to the treatment of that mentally ill person. Now, it would be logical and in keeping with the current trend of time that the money follows action. In other words, if you close a hospital and you say, I'm not going to do this hospital anymore, then you would have to give the money that you spent per day for the patient in the hospital to the family. And that would be a decent way of doing community care, because there is a government as such is supposed to help the health of their people. And how do they do it? They build a hospital. Now they close the hospital, but the cost of treatment has not been transferred now to the family. It's not been transferred into the community. So that's one financial transaction which is very huge and completely invisible. There is nobody has calculated how much it costs to keep a person with dementia at home for 10 years, who is paying for it, etc. All that we know is that the government says we have improved care because we have closed the hospital. But somebody else has picked up the bill, and the somebody else is invisible. There are very few carers who are given recognition for what they are contributing in terms of money to the treatment of mentally ill people. There is only one psychiatric society in the world which is recognizing once a year one family which has done particularly much for their member, the sick member, more as a symbolic action. But this first financial transaction is completely hidden and invisible. And it's a bad thing, because we should really make sure that the family which receives the patient and will provide care is in fact sufficiently supported to be able to do that. Otherwise, the family as a whole will fall apart. They will not be able to do it, and the patient will be returning to the public care or end up in a graveyard or in the street or somewhere else. So that's one aspect of money. It's the money which does not follow action. Its present money is considered separately from action. The second part of this story is that, of course, the mentally ill people who are employed can be have a financial transaction which is of two types. One is what is called being absenteeism. That is, they miss coming to work because they cannot work for one reason or another. And that is so while they're not working, they still receive some salary, but it's a loss. And then there is the second part of that money, which is presenteeism. That is, people who come to work, but because of their illness, don't perform well. They sit there all day long, but they do nothing. They're just present, but they are not contributing. So that's another financial transaction, which is very important. Now you come to the last part, which is yours, where you say, why so money for research and not money for something else? The only visible money where you can apply to get money is for research at present, because the rest of the financial transaction is hidden in the government system or in the private care system, where nobody tells you how much money there is, how much money will be spent, or what is spent. The only place where you know how much you will get or how much you spend is when you apply for a grant, which tells you that is the amount of money which we are spending. So that it's a much more complex situation. And one of the great problems for medicine in general and psychiatry in particular is that that we are completely blind to most of the financial transactions. And yet, medicine has become at present an economical proposition. It is no longer a humanitarian affair. Now, private hospitals are growing all countries of the world. Medicine has split itself into many small disciplines because being a master of the small discipline gives you a higher salary and you earn much more, etc. All of these are financial transactions which are going on and are completely invisible when you look at them from the outside. The only thing that you know is I apply for a grant, I get a grant, and then I use the money for research. But all the other money aspects, nobody speaks about.
Well, thank you very much. This is again a really mind-opening answer from you. I might ask another questions, but I don't know, maybe I can like skip my order and then later ask my other questions again. That would be
okay.
I can ask my question if it's free. Hello, Dr. Sartorius. Thank you for being here. You have been in that field for many years. That's why I want to ask specific question. Like I'm fifth year medical student, and I want to be a psychiatrist. And I mean, from your experience, what do you think? Which parts are most efficient in psychiatry, in like clinical or preclinical side? And I mean, what can you advise us to, how can I say, attribute or just contribute more for the future psychiatry?
Yeah, well, I think that it's very important for a psychiatrist, perhaps more than for other doctors, to like his job. A psychiatrist must love psychiatry or leave it, because doing psychiatry without wanting to do it, without being emotionally linked to it, is not a good thing. It makes you unhappy, it makes your patients unhappy. Now, what is the essence, the very essence of psychiatry is composed of three components, like any other medical intervention. And one part of that is the actual treatment which we are giving, the tablet, for example. The second aspect of it is the belief of the patient that this tablet works, which is the placebo effect. You all know about that. And then the third aspect is what has been called the non-specific aspects of treatment. The non-specific aspects of treatment are the emotional bond that you have with the patient, your wish to help the patient, your readiness to listen to what the patient has to tell you, your respect for the patient's problems, your concern about the family of the patient, and all of these things. So medicine is composed of those three factors: treatment method, placebo, and the non-specific aspect. Now, psychiatry basically is in the third area where it spends most of its time, which is thinking of ways in which one can deal with empathy and with making the person get the treatment. Because the treatment with medications in psychiatry is a very great help, but it's far from being more than 1/3 of the treatment as such. So what will make psychiatry particularly important is, I think, would be precisely this third aspect of being aware of the person who is in front of you and thinking about that person, and in a way making that person get better. Which means, in other words, that in every single good doctor, at least 1/3 should be a psychiatrist. The other 2/3 are a little different, but 1/3 should be a psychiatrist, which means that our training for medical students, for example, has been to a large extent incompetent. We should think that normally you should never learn about anxiety in the department of psychiatry. anxiety should be taught at the surgical ward when a person is having an operation tomorrow and is afraid of it. And the psychiatrist should teach you how to diminish anxiety in that person at that point, not in a department of psychiatry, sterile surroundings, but in the actual situation where an anxiety is present. So that psychiatrists will or should be masters of these non-specific aspects of treatment, as well as being masters of the treatment with medications and the treatment in terms of constructing the life of or helping to construct the life of a person with mental illness. Because many of the people with mental illness, in fact, have to be helped to reconstruct their life. And it's more than many other doctors will be doing. So being a psychiatrist, I think you will be, primarily should be a good doctor. And you should be in constant contact with everybody else, much more so than any other discipline. Psychiatry, in a way, should be the closest to general medicine, not as far as it's at present. At present, it's very far away. You go to mental hospitals to do psychiatry. But psychiatry is the most, the closest to good medicine in general. Now, I'm not quite sure whether I'm replying your question, but I think that what I would like to leave with you, if you are in 6 years of medical school, as you go and finish your medical degrees necessary, you should probably spend some time in psychiatry and with psychiatrists to see whether you like it. Because your life will be better if you accept the discipline because you really know that you like it, rather than to start it with half-heartedly. I think psychiatry, more than some other disciplines, depends on your emotional relation to the discipline as such. And I think that if you know this, you will become a good psychiatrist and you'll also be a happier person. But if you are not sure about this, better wait before you go into it completely.
Yeah, I get it totally. Thank you very much.
Maybe we can have some other burning questions from other members of the meeting.
This is an example of psychiatry, how it should be taught. One of the things that you should have learned as students, and nobody, unfortunately, is teaching this, is a variety of social and professional skills. We are currently having a series of training courses in which we train people in professional skills, only because nobody else has done it before. Professional skills, for example, how to not be afraid to ask a question, and how to formulate a question in a manner that will, number one, express what you want, and number two, you will not make a fool of yourself by asking it. It's a skill that can be learned. And I think that the only way to learn it is to exercise it all the time and to think about it. So that's just a side comment on my side.
If you continue hesitating, as an old medical student, I will ask one. All right. With your permission, dear young colleagues, now, dear Dr. Sartorius, you know, we have gone through a terrible disaster again. And I know many of our students, especially, want to be useful for the victims of the disaster. But we have some discussions among ourselves. I know these friends have discussed this question together with me and some other friends. We are not sure what people from other parts of the country or other parts of the world can do. Could you share with us your thoughts on this issue?
Well, there is all disasters, and I'm terribly sorry to hear about the disaster which you have just experienced. all of the help to people who have been hit by disasters are probably based on elementary human and humanistic help. What do people who have been hit by a disaster need most? Do they need psychiatry? No. What they need is information to know what will happen with them, what happened to their family, will it be another one? So information is one important thing. They want to know where the rest of the family is, so that they want to know how this will happen. They want to know. There's a number of questions which are extremely humane and important in daily contact with people, rather than highly specialized services that we can offer them. The psychiatry of the, if you wish, of the hospital type is the last that we need for that situation. There are some people who will break down under the stress which they are experiencing, but this is a small minority of them. For the majority of people, they need information, shelter, and a prospect of the future. And they also need to know what will happen next. And since we don't know this, the information system in a disaster situation is so terribly important. Now, it is a logical consequence of a disaster that people's heart opens and they go there to help. But it has been shown that this is not such a very helpful idea either. That unless the help is organized in a correct way, many of the efforts to help are in fact disturbing. They are bringing in a mess, which is not necessary. So the chief challenge is how to organize help to people who have been in a disaster. And the second one is then, who are the best persons to provide this particular help that is characterized for this particular disaster? And I think that to go there and to want to help, there are three ways to do it. Number one, you send the money to somebody. Number two, you say, I'm ready to go, but I'm not going there until they invite me and they tell me what needs to be done to see whether I can in fact do it. Because maybe you're not competent to do the things that are particularly necessary at this time. And I think that so for any specialist medical professional, he has to wait for the disaster organization to tell them what they can do and when their need is necessary. So I think that probably solidarity, perhaps sending money or things like this are certainly very useful. And insofar as our direct help is concerned, we have to be guided by the disaster team, which very often can be created and which is present. In many countries, they have had now a lot of what has been called disaster preparedness, in which people during the time when there is no disaster, they define who will do what if a disaster breaks out. But many of the other countries are not doing this. They are too optimistic. They see disaster will never strike us. So they do nothing to prepare themselves for a disaster. And I think that it's an important aspect. There's a wonderful set of documents which you may wish to read, which has been issued by the Pan American Health Organization on disaster preparedness. They also have a center for disaster preparedness in which you can get documents and materials about that.
Thank you very much.
Well, I might expand the question more, maybe. Like apparently the people in there experienced like big traumas. They lost their loved ones. They've seen the scenes that is like unbelievable, like a horror film, and this will like apparently cause some sort of like a psychiatric endemic in the area. So as a psychiatrist or people like interested in the mental health awareness, what should you to advise? I mean, how can we help to prevent the endemic of this psychiatric disorders in that area, and in the whole country? Actually, it was traumatic for all the people.
Well, the first thing that psychiatry should or could be doing is, before any disaster happens, to think of what could be done during a disaster. What should a nurse learn in addition to what she learns now that would make her helpful in the case of a disaster? What is it that a doctor, a general practitioner, should know in order to be able to use it should a disaster break out? So one big effort is to think about what kind of training should we give to all of the health personnel in order to be ready for the disaster. Maybe they're not ready on this time, but to our great disaster, the problem is, of course, that other disasters will happen. And we should, now that we understand that they need to do something, we should think about how to train people to be ready to. How to listen, for example, is a skill which is tremendously important. It's not being taught. You cannot learn how to listen unless you have been trained properly. Some people are gifted by God to be able to listen, but most of us are not. We have to learn how to listen, listen in a positive way. And I think that it's one of the several skills which should be introduced into the training of people who are likely to be helpful in disaster situations. Unfortunately, practically no countries in the world, even those who are very frequently victims of disasters, has prepared themselves sufficiently well to be ready to do something, because disasters are rare events. And as soon as the event is over, everybody wants to forget it as soon as possible because it was so terribly painful. In fact, instead of saying, no, now that we know it's so terribly painful and it causes so much problem, let us make sure that everybody has in fact got some training. I do not know, you are a medical student or?
Well, I have just graduated the previous term.
So you think back about your training over time, how many hours did they train you how to behave in disasters? Well, the same question is for everybody. You ask a psychiatrist, how many hours did you learn in the course of your postgraduate training about disasters? 0. It's considered that disaster is just another thing. Well, it isn't. Disaster has certain characteristics which are unique for disasters. And these characteristics need specific skills. And those skills have to be trained and learned. How to listen is one of them. What to ask is another question. How to face a patient or how to face a person who is not well in a disaster situation. There's a whole range, and people who have gone through the disaster once now will remember many things, and they should be invited in principle to go and teach the medical student what to do when a disaster breaks out. As a general practitioner, as a psychiatrist, as a surgeon, or as whoever it might be. Because the errors which people make in handling disasters are huge. And the amount of money that is spent is very often enormous, and it goes wasted. Not to mention that it goes into criminal hands.
Yes, that's so true. And as a country where we have this huge risk of earthquakes can occur, I think we should include this disaster planning sort of lessons to our education, definitely, like both of the specialty educations and basic medical.
Well, the learning about skills which are useful in disasters are also useful in daily work, because people who come to you into your clinic are often victims of personal disasters. And you have to think about how to handle their personal disaster as well. It's the same skills. It's the same way of approaching the matter that you will have to learn. In addition to the measures that will be taken by an authority which will be invited to help with the disaster situation. I see that Dr. Pinto da Costa has shown up, her face at least is not visible for the moment, but that will be corrected, no doubt, in due course.
Thank you, Professor. I'm traveling, but it's always like inspiration to hear you. I'll show my face when I can.
Right.
Yeah, Sena, will you please go ahead and ask?
Okay, thank you. I'm Ekin, a friend of Sena's, and wanted to attend the meeting because I'm very interested. I had a question about the fields of interest in psychiatry. As a very experienced psychiatrist who have extensive experience both in neurology and psychology, I wanted to ask you, can you please expand on the differences in point of view and approaches in psychiatry versus neuropsychiatry versus psychology? Because as medical students, I'm a fourth-year student at a medical faculty. We are not very informed on the differences between these fields extensively and have to make decisions in between these fields when we have to in a snap of a decision, like not very informed about the differences between the fields. So I wanted to ask you that.
Right. Now, there is a correct definition, and then there is life. And the two are not necessarily completely overlapping. In principle, psychology is a discipline that studies the mental functioning of human beings and animals. It does not deal with the treatment of anybody at any time. It's a scientific discipline. Even the name, which ends in ology, means that it's a science and not a treatment. Then there is psychiatry, which is a discipline that has been defined by its focus of helping or treating people who have a mental illness. That was in the late 19th century. They got their name as being psychiatrists. That is the psycho and iatros, meaning the mind and doctoring, mind and healing. So that's the psychiatrist. And he is supposed to deal with mental illness of different descriptions. That's all in theory. The third group that you mentioned is the neurologist, who is supposed to deal with problems that are due to organic damage to the neural system. So that if you have a nerve that is broken by a knife, that it gives a paresis, which is the subject for a neurologist. Equally so, if you have a tumor that grows in your brain, it's a matter that a neurologist should be able to diagnose. But reality is a little different. Psychologists are very often, with additional training or without additional training, undertaking to treat mental illness. Although themselves, they are not really competent to do this because they are not trained how to recognize physical illness in their training. They are, in fact, not learning about, for example, the fact that if you don't have enough water to drink, you're likely to have a particular psychiatric symptoms which will appear. They're not learning about it, but they're doing it nevertheless. In some countries, the psychologists can only treat mentally ill people under supervision of the psychiatrist. A psychiatrist will invite or send a particular patient to be treated by a psychologist who can deal with certain techniques which he or she had to learn after the training of psychology has been over. So a psychologist has to learn additional techniques and then will work either alone, that is independently, or under the supervision, depending on the legislation in different countries. Now, there are people in the previous time who said the brain is an organ which makes you think, hence it is stupid to have this division. So let us have a discipline which is called neuropsychiatry, which is in fact covering the whole field. And until the 60s or 70s, most of the countries in the world had in fact a training in neuropsychiatry. It's only then that the two disciplines separated, the neurology and the psychiatry, partly because the amount of knowledge that was available has grown so very much, and because some treatments for these have become possible, complicating the field quite considerably. Now, psychiatry is also gradually splitting into a variety of sub-disciplines, some of them closer to thinking about organic damage, which is identifiable, such as Korsakoff syndrome or dementia or something like that, and those where the symptoms of psychiatric disorders are present, but the organic basis is unknown. And some of them, they have split in those two directions and gone with the extreme being the psychotherapists, people who exclusively do psychotherapy on one side, and people who are doing organic psychiatry on the other side. The neurologists have more recently said, no, but we are not happy with what you're doing. Since the organ which is responsible for thinking is the brain, we should not speak about mental health any longer. We should speak about brain health, because it's a healthy brain which makes you think well and makes you operate normally. So to speak about mental health is a nonsense. We should not do this. These are another branch that goes its own ways. So that I think that between the three, probably the limits vary from one country to another, and the sense of responsibility is different in different ones. Basically, psychologists in most parts of the world are not allowed to prescribe medications. In some countries, it is now permissible under supervision to extend the prescription of medication. But basically, they are not allowed to prescribe medications for any disorder, including psychiatric disorders. Now, when you, as you grow, you will discover that many of there are now new disciplines which have come into existence. There is, for example, a university which is currently having its seat in Vienna, but also has a branch offices, for example, in Paris, which is called the Freud University. And the Freud University trains you in psychotherapy, and the preparation to be trained in psychotherapy is zero. Anybody, regardless of their training previously, even without elementary school, can become a psychotherapist, provided that he has provided psychotherapy under somebody's supervision for a sufficient number of hours. I think the total number of hours is 5,000 or something, but once you've been treating people or being involved in treatment of people for a sufficiently long time, there you are a psychotherapist, and you can then treat psychotherapy. The legislation about who is allowed to do what is unfortunately very often old-fashioned. It's different from one country to another, and it's not very precise in what should be done and who should be doing. I myself believe that the psychiatrist should be a fully trained medical doctor who is aware and competent to deal with physical illness, but has selected to put major emphasis on the treatment of mental illness. While a neurologist is a person who is a fully trained medical doctor, but has concentrated on the functions of the neural system, with an exclusion, however, of the more complicated psychiatric problems that might arise, probably as a consequence of brain damage, but without knowing that this is happening.
Thank you, Professor. And I would like to ask, what are the benefits of psychology education besides psychiatry training?
Whether psychology is useful, you mean? Or how they are trained?
No, I mean like PhD.
Now, all three of these disciplines that I mentioned can, after they have completed their training in the clinical methods or in anything else, they can also do research, and the grounds of the research, they will then, depending on the rules in different countries, at the end of that additional research and maybe some training, they will get an additional degree, which is a Doctor of Philosophy. And this is called the PhD. And some people have a course of 2 to 3 years, during which they will have to do learn a variety of things, ending with the examination and the thesis that they write about the work that they have done. And that will give them the degree of the Doctor of Philosophy, PhD. Now, some other people do not require you to go to any training, but require that during a number of years, you write a number of papers, which will be accepted by the fine journals. And if you have a sufficient number of papers published, taken together, they will be equivalent to a PhD thesis, and therefore will give you the right to get a doctorate in science. So basically, a PhD is a doctorate of science that anybody in the medical field and in psychology could get with additional work, research, and some training.
Thank you. I have one more question. What are the differences of psychiatric practice between different countries in your experience? I would like to practice psychiatry in a different country.
Well, there are in the Eastern European countries, which were at the time under the strong influence of Russia and the Russian psychiatric schools, psychotherapy was practically not done and not accepted as a discipline in its own right. While in particular in the United States of America, there was a very strong movement of people who were doing exclusively psychotherapy, and they've been trained in a variety of ways to become psychotherapists, doing nothing else but psychotherapy. So these are the two extremes, if you wish. The one which says there is no psychotherapy, and every treatment that has to be done by a doctor who is trained as a psychiatrist, and the others who say, no, if you know enough about psychotherapy and about Freud's writings, etc., you can become a psychotherapist and you are a legitimate person to deal. And the laws have covered those things. The laws are extremely different from one country to another in terms of what is recognized. The European Union has, over the years, tried to bring as much as possible of a mutual recognition of medical degrees, and to an extent also the specialty degrees, although this is not yet a completed work. They will have to work a little bit more to be sure that you can. So what you have to, if you want to work abroad, you'll have to look at the country, specific legislation in that country. There is no thing that you can learn in general about them anywhere.
Thank you.
We are in the last 5 minutes.
A famous
Dr. Sartorius has another appointment. Irem, please go ahead.
Okay. Thank you for this meeting. I will just add a small question to Sanal's question. Like it will be like an adding. So what are your thoughts and experiences on practicing psychiatry in other cultures or in a different language than your own mother language?
It's a very important question. Because what is called the idioms of distress are so very different, and people speak about their feelings in so different ways. For example, the question of when you speak about the heart, in some countries, sadness is expressed by saying my heart is broken, while in other places you would never mention the heart in talking about. When you go to the Bantu fields, they will speak about anxiety using the word for a branch of a tree that shakes after the birds have run away. That is what they use as a picture to describe anxiety. So if you want to work in another country being a psychiatrist, you have to spend the time to learn the specific idiom, the specific language of distress. You have to do it for medicine in general, but particularly for psychiatry. You have to learn how to work in another country by learning the laws of this other country and learning what people say, how do they speak. And what is important also will be to learn the difference between the denotation of words and the connotation of words. I don't know whether you're familiar with those two terms, but the denotation of the word is what it says in the dictionary. For example, it says an apple is a round fruit. The connotation of the word, however, is the apple is symbol of love, or the apple, I love apples. It's the emotional reaction that is linked to the word. Now, the direct translation from one language into another very often forgets that the translation is not only the meaning of the word, but also its emotional impact. And so it will take some time for a person who wants to work in another country to understand, even if he speaks the language very well, to understand what people think when they are saying a certain thing. Because very often you can be insulting somebody very much by speaking what you think is the right language, but you are speaking in terms which are unacceptable. There's a lot of work that has been done, and one of the instruments that you might wish for fun to use is what is called the Osgood, OSGOOD, Osgood Semantic Differential. The Osgood Semantic Differential is a series of scales on which you put a word, and then you ask people to judge, where does this word, does it excite them, does it not excite them, is it warm, is it cold, etc. And it gives you a profile of a word in different languages, and on your own language as well, if you ask people about it. But the learning of psychiatry in another language involves much less of learning about psychiatric disorders and much less about the culture and setting in which you are living and which your patients will be living. Their ways of thinking, their ways of speaking, their ways of feeling.
Could you please spell that word once more?
The name of the author is Osgood, O-S-G-O-O-D, Osgood, and the name of the instrument is the semantic differential. And I mean, there's a whole range of writing that has been going about this, but it's an interesting thing to compare words in this. And every word as such has a semantic sphere. So if you want to play with this a little bit, which we had to do very often by translating a psychiatric instrument from one language into another, you can explore the semantic spheres. How do you do that? You take a word like love or apple or, I don't know, house in Turkish, and you write down all of the synonyms for that house, for that word, right? Then you take the dictionary of the other language and you write out all of the synonyms in the other language. And then you try to see how many of the synonyms mean the same thing. And you'll discover that the overlap between synonyms is, depending on what the subject is, between 60 and 5%. So that you will find that some words which you're using thinking this is the right word to use are having terribly bad effects because they are meaning a very different thing. So do it for one or two words and you'll see it'll be an interesting exercise for you.
Thank you so much. I will absolutely try it.
Okay.
Mariana liked that idea because she lives in another country.
Yes. Yes. She lives in 3 countries.
Or more. No, I think that's a very interesting comment. For example, like in English, before I moved to the UK, I used to say, with all due respect. And in England, to say with all due respect, it's very insulting. It's actually, you don't really respect the person saying that. So that's a very interesting.
There are so many expressions that are, in fact, can break your friendship with people. So very often, the most powerful international word is a smile. A smile overcomes everything. A smile overcomes your incompetence. A smile overcomes your uncertainty. Smiles overcome so many things. So when you do not know what to do, smile. It helps. Most often, it helps very much.
Hope to see you in another meeting.
Yes. Yeah, I hope to see all of you sometime in real life and to talk to you and touch many other topics. Thank you very much for inviting me.
It was a pleasure again. While closing, do you want to say anything?
No, good luck to you all. I think that is what I'd like to say. So many ways. I mean, you have so many years of life before you. So I think I wish you luck for all of them.
A picture of today. Thanks a lot.
All right. Okay. All the best. Thank you very much. Thank you.
If our friends would like, we can continue discussion while Dr. Sartorius goes to another meeting. but we will not, use the YouTube anymore.